So let's take a look at chapter 16, which is going to be the cardiovascular emergencies. And this is going to encompass a lot of different things. We're going to talk about some things that can cause chest pain and what's actually going on inside of the heart. So cardiovascular disease itself has been a leading cause of death for Americans since around 1900 and generally accounts for 1 of every 3 deaths. We can help reduce this by helping to encourage healthy lifestyles, having early access to medical care, so encouraging people to follow up with regular doctors and not waiting until things are emergencies, having more CPR training of lay people, so that means bystanders as far as looking at sidewalk CPR, hands-only CPR, early access to AEDs in public places is definitely something for us to think about too. Increased use of technology for dispatch and response, recognizing the need for ALS, and the use of cardiac specialty centers when they are available, which we're going to talk about a lot more in here. Anytime that we think a cardiac event is going on, we want to try to get that patient to that correct definitive care, which would be to a cardiac capable facility, as long as our policies within our agency will allow us to do that. So let's take a look at some anatomy. We know that the heart's job is to pump blood to supply oxygen-enriched red blood cells out to tissues, and the heart itself is divided into right and left sides, and then in the top and bottom, the upper chambers, the atria together, so the right and left atrium, and then the lower chambers, which are the right and left ventricles. And so this picture here just re-emphasizing how that structure is. We've previously talked about blood flow through the heart whenever we were talking about the anatomy of the human body and overview of that, so you can go back and check that video out or look up any resources related to blood flow through the heart if you're not sure how that works. We'll be addressing some parts of that throughout this PowerPoint as well. So the atria receive that incoming blood, and they're going to receive that from our superior and inferior vena cava, as that's returning blood from different parts of the body. So your superior vena cava is returning blood from the waist up, and your inferior vena cava returning blood from the waist down. And then the ventricles are going to help pump that outgoing blood as it pushes it out through the rest of the body. And that's going to be directly related to your aorta, which is that body's main artery, which receives the blood from the left ventricle and sends it out to the rest of the body. And the one-way valves inside of the heart keep the blood flowing in the proper direction, so we don't have blood backing up. Now, the heart's electrical system controls the heart rate and coordinates that atria and ventricles on how they begin to pump and how fast they pump. And so we've talked about that term before, automaticity, meaning that the heart is creating its own electrical conduction. So it allows for spontaneous contraction without a stimulus from a nerve source, and that's what makes that cardiac muscle tissue so unique. So we're going to take a look really quick right here at the different pathways and where the impulses could be coming from. What you need to know is that SA node, or the sinoatrial node, which is this green spot right here. That is the heart's primary pacemaker. And so that's where electrical impulses should originate from. Okay, and so generally we can expect the heart rate to be between 60 and 100 beats per minute when it's coming from that SA node. Now, if the SA node fails to fire, then the heart's backup system is the AV node, or the atrioventricular node, this blue spot right here. And we can expect the heart rate to generally be between 40 and 60 beats per minute if it's coming from the atrioventricular node. If that fails to fire, then it'll come down just a little bit and the bundle of His might fire, and so we're still anticipating around 40 or so beats per minute. But if that fails to fire too, then what's happening is all of these small fibers, the Purkinje fibers, all throughout the heart muscle, and this is just giving you a few examples, but really these encompass the entire heart, will begin to fire on their own. And so generally, if it's coming from the SA node or the AV node, the impulse will start where it's coming from, and the signal will be sent down through all of these to the Purkinje fibers so that they contract at the same time. But without that stimulus, the Purkinje fibers are attempting to fire on their own. And so when you get a lot of uncoordinated electrical firing like that, that's where we run into ventricular fibrillation. And so ventricular fibrillation, which we know the patient would be in cardiac arrest, that's one of our shockable rhythms with the AED, that's where we're starting to see, again, a lot of that uncoordinated electrical firing that's happening there, and the heart is just essentially quivering, and we can't sustain that. We can't live like that. So important for us to know these different pieces, what kind of heart rate is associated with that, and definitely what is the primary pacemaker, which is that sinoatrial node. So the autonomic nervous system helps control our involuntary activities. So that's what sets like our heart rate, our respiratory rate, helps to control our blood pressure, things of that nature. And there are two parts to this, which we've discussed previously, and that is the sympathetic nervous system and the parasympathetic nervous system. Now, the sympathetic nervous system is our fight or flight response, and so here we can expect to see an increase in heart rate, increase in blood pressure, dilation of pupils. We can also see a reduction in urine and feces production as the body wants to hold on to the nutrients that it has in its panic mode. And then the parasympathetic, or rest and digest, where we would see a decreased heart rate, decreased blood pressure, decreased respiratory rate, more constricted pupils, and then an increase in production of urine and feces, where this is where we operate most of the time, where the body is in its normal working order. Now, the myocardium needs a continuous supply of oxygen and nutrients to help pump blood. So remember, when we were talking about shock, we talked about the perfusion triangle and how we need to not have any interruption with that perfusion triangle as far as the pump, which is the heart, the container, which is the blood vessels, and then the fluid or the blood. But we've also got to have an adequate amount of oxygen and nutrients and an adequate ability to remove waste products. So increased oxygen demand by the myocardium, how the body responds to that is by attempting to widen or dilate the coronary arteries on its own. But sometimes it can't do that, and that could be due to a blood clot. It could be due to plaque buildup or loss of elasticity inside of those vessels, which we're going to look at throughout this PowerPoint. And so when the body can't meet those needs, that's where the patient would begin experiencing chest pain, because they're not having the ability to get oxygenated blood to that area of the heart. Ischemia is occurring. So the coronary arteries are the blood vessels that supply the blood to the actual heart muscle, and these start at the first point of the aorta, and they move around and supply the heart. And so you have the right and the left coronary artery. And this picture here is just showing how those right and left coronary arteries feed the different areas of the heart. And so this is really not that important at the EMT level that you understand how those work. But if you were to progress up your learning all the way to paramedic level, then this is a lot more important, where you start to understand which area of the heart is actually experiencing an infarction so you can treat the patient appropriately. And so really important for us to understand as we progress forward. But right now you just need to know that those are there and that they are supplying blood flow to the heart. Those arteries supply oxygen to different parts of the body, so as they progress out and it's moving out to the rest of the body, these are some of our major arteries. So we have our carotid, which supplies the right and left subclavian, which is underneath our clavicle, the brachial arteries, again, right and left ulnar, right and left iliac, right and left femoral, the anterior and posterior tibial. And as those arteries branch down, they become smaller arterioles and then ultimately capillary beds. And those capillary beds connect over to the small venules, which become bigger veins. And so we've spoken about this before, how this is all one inner working system of blood flow, where oxygen exchange, where nutrient exchange, where waste products are exchanged in those capillary beds. So we've got to have a good working system for this to work effectively. And again, ultimately, those veins become larger veins all the way leading up to our largest, which is the vena cava. And that superior and inferior vena cava are what return the blood back to the heart to go through the entire process again. So this is happening many times each minute. As every time that your heart beats, this is what is occurring inside of your body. Blood itself, we know, consists of red blood cells, white blood cells, platelets, and plasma. And so we've got really a dynamic here that needs to stay the same. And remember, that level of staying the same all the time is homeostasis. And that's what the body is trying to achieve. So if we have too much or too little of any of these things at any given time, it could be bad. We don't want to have too many or too little red blood cells, white blood cells, platelets, or plasma. If we have too little red blood cells, we might be anemic. And so we would have lost the ability to carry oxygen. If we have too little white blood cells, the body won't be able to fight infection, but too many of those could indicate some type of disease in itself, like leukemia. With platelets, too many platelets, and the blood is going to clot too often, creating blood clots. Too little platelets, and we would be facing something like hemophilia, where we're unable to clot, and everything could be life-threatening. And then also plasma. Don't want to have too much or too little of that as well, which is the fluid portion of blood. Now, the blood pressure is the force of the circulating blood inside of the artery walls. And so we know we get that systolic blood pressure during the contraction phase and the diastolic blood pressure when those ventricles are at rest. We can feel that pulse during the contraction phase or the systolic phase, and our peripheral pulses are what is felt in our extremities, and the most often common site that we use for that is the radial site. And then the central pulses are what's felt near the body's trunk, and so we use the carotid and the femoral sites for this. Now again, there are other peripheral pulses, and you might be checking those depending on what's going on with your patient, if you're assessing PMS or you have an injury that you're assessing the distal pulse for. But just on a regular basis, that radial site is the most common that we would use to check peripheral pulses. Now, if we have an absent radial pulse but a present carotid, that of course doesn't mean that the patient needs CPR. That just means that their blood pressure is low. And so depending on what literature you're looking at, that could be less than 80 or less than 90 systolic. But it's not until the absence of a carotid or femoral pulse that we would actually want to begin CPR. So those up top are going to be our central pulses, and down at the bottom are our peripheral pulses. Looking at cardiac output, that's the volume of blood that passes through the heart in 1 minute, and we get that using the formula of heart rate times stroke volume. Now again, stroke volume is not something that we will measure and assign something to in the field. The way that we really measure cardiac output in the field is by looking at the pulse, rate, rhythm, and quality. And if we have a good rate, rhythm, and quality, we have a palpable peripheral pulse, and there's no issue with the regularity or anything with the pulse there, then we have a good cardiac output. If we don't, if something is wrong with the rate, the rhythm, or the quality, then we would be more concerned about the cardiac output. Now, perfusion is the constant flow of oxygenated blood out to tissues, and we're usually more familiar with the term hypoperfusion, which would be a lack of that, which is where we start talking about shock. Again, the requirements for a good perfusion are the perfusion triangle, and so that is again our pump, which is the heart, the blood vessels, which are the container, and then the fluid or blood to fill that container. So that's our perfusion triangle, and all three parts of that must be working adequately, in addition to having an adequate amount of oxygen, nutrients, and the ability to get rid of waste products. And again, if perfusion fails, then cellular death will start to occur. And remember, if enough individual cells die, then we start having tissue death. If enough parts of the tissue die, it might cause organ death, which could lead to organ system death, and eventually death of the organism, which in this case would be the human. I'm going to stop this part of the video here, and I'll catch you guys in the next part.